To our meeting, a wrap up and a look ahead. I am Judy Barton, and I'm going to get a few rules underway just so that it's runs smoothly tonight. First off, we are recording this meeting. It will be posted to our YouTube channel, and then we'll also email a link out sometime probably early next week with any resources shared during this meeting as well. Please use your raise hand icon and when you want to ask a question, and then wait to turn on your your microphone until you are called on to ask a question, just so we don't have a lot of background noise for people. You are welcome to turn your video on if you would like to.
No, but that's okay. I can hear them.
And
the important part for me.
Yeah.
We are ready to get started. I'm going to hand it over to Ian.
Oh yeah.
You'll hear the explanation. He's pretty loud and clear.
Ian?
Hello. Hi. Good evening, everybody. And thanks for joining us for this, our last educational offering of 2021. We appreciate you taking the time to be with us this evening. Our speakers this evening and our agenda will include, you just heard a welcome and some brief instructions from our administrative coordinator, Judy Barton. I'll go over the program for this evening in a minute. Our speakers this evening are Kip Sullivan, Ann Jones, that's me, Ken Engelhardt, and Rose Roach. At the end, we'll have a few announcements and a call to action and a wrap up from Judy and a little post-meeting information. So, a wrap up and a look ahead. This evening's a little bit of a blend of topics. Kip's going to do a quick review of the fall seminars, kind of summarized as managed care failures and lessons not learned, with a few minutes for question and answer on that subject. Then we'll go into the second part of our program, and that's I will make a few introductory remarks about ongoing threats to Medicare and Medicaid. Kip will summarize the rationale for Medicare Advantage, and then mostly go into an explanation of a payment model that further privatizes Medicare, something called direct contracting entities. It does have a lot of information. We may or may not have time for questions after that, and I know that you'll have some, but we'll see if we can make that clear and perhaps have time for a couple questions. Then Ken is going to wrap or talk about looking ahead, building a coalition of like-minded organizations to run a campaign for a bill, working to win a Minnesota health plan and then improved Medicare for all. And then Rose Roach is going to talk to us about the Minneapolis Health Plan Caucus that is forming in our legislature, and also her experiences with giving a presentation on the situation with our current healthcare payment system to that caucus. And I'll finish up with some announcements and then 2 calls to action regarding Medicare. So I will, I think now, turn it over to Kip Sullivan, health policy analyst with Healthcare for All Minnesota, and a review of the sessions this past fall. Don't worry if you haven't attended those sessions either. We have those recorded, and you can always go back and review those. So go ahead, Kip.
Thank you much, Ann.
Okay.
Those of you who saw the webinars, remember they were September, October, November, you know that I spent very little time on the symptoms caused by the high cost of our healthcare system, number of uninsured, examples of the physical, emotional, and financial pain this crazy system inflicts. I devoted 98% of my time to explaining why our costs are so high, and I did that by reviewing the history of the debate. I just, over the years that I've taught this, I find that it's easier to teach it and easier for people to understand the good and the bad ideas that are involved in the debate, rather than trying to explain what in the heck managed care people are talking about. Is to walk through the history of particularly of the managed care movement, as well as the single payer movement and high deductible advocates. In the first seminar, the September seminar, I did an overview of the history of the debate. And we saw that the participants in this debate about why are costs so high fall into three categories: single payer, managed care, and high deductible policies. I devoted most of my time to managed care because it has hogged the spotlight for the last 50 years. The modern healthcare reform debate really opened with a bang in January of 1970. So we're well into a half century in this debate. US and Minnesota cost containment policies are based almost exclusively on managed care's diagnosis and the managed care solution. The diagnosis from the managed care folks is that US and Minnesota costs are high because patients get too many healthcare services. We overuse healthcare. And in the managed care world, that is caused by the fee-for-service method of paying doctors. That's their diagnosis. Their solution, of course, follows from their diagnosis, and that is to antidote the fee-for-service incentive by subjecting doctors to financial incentives that induce them to deny services, to limit patient choice, and to micromanage doctors. Utilization review is the most prominent example. Making doctors, for example, get permission before a patient can be hospitalized. The planning for these three webinars began last August. There were a number of us involved. And we managed to cover pretty much what we hoped to cover. I'm just going to read to you an outline of the table of contents. I'll post it in about 20 minutes, 30 minutes when I get back on to talk about the direct contracting scam. I'll post this. You don't need to take notes. But here's essentially the outline of what we thought we should cover. First, that costs are very high, including in Minnesota. Here in Lake Wobegon, we think we're an efficient state. We're not. We're 10% more expensive than even the US, which is the most expensive place to get healthcare on the planet. Two, if you're concerned about total spending, you have to be concerned about both the price of whatever we're talking about and the quantity. And the debate in this country about what's causing our high healthcare costs and what to do about it is essentially a debate about whether we think excessive price is the problem or excessive quantity is the problem. It is rarely described that way. I wish the media and other people teaching this would describe it that way, because it's a great place to help people that are just getting used to health policy to make sense of a rather complicated debate. Managed care and high deductible advocates endorse the excess quantity theory. The single payer movement has said, no, the correct diagnosis is excessive price. Three, we're going to review the evidence rebutting the managed care diagnosis, the evidence against the overuse diagnosis, and for the excessive price diagnosis. Four, if prices are the problem, then the next logical question is, why are prices so high? And the answer is soaring administrative costs and galloping consolidation, both of which were worsened by the managed care proposal. Then evidence indicting the managed care solution. HMOs harm people, they provoke mergers. And six, evidence indicting the high deductible solution. They harm patients. They really can't cut costs. And seven, the last section, how single payer addresses high prices. We didn't plan to do a lot of teaching in this webinar on single payer because of the audience we're talking to. But we did manage to cover pretty much everything else. There were three exceptions. We didn't get to talk about report cards. You may recall that was one of the arguments Paul Elwood made to the Nixon folks. What happens if HMOs harm people? Oh, well, someone's going to do report cards. We should come back to that because it is still a hot fad. There are a lot of people who think quality measurement can be done accurately. And if it's done accurately, people can shop better for healthcare, and that will bring costs down. A fantasy, it won't happen. We didn't have much time to talk about high deductible policies and a new fad called price transparency. You're probably hearing about a rule that the Trump administration announced toward the very end of the regime, which they're basically requiring hospitals to report prices on 300 healthcare services. That will also turn out to be a joke. We should perhaps talk about that in January, February, if that's of interest to people. And lastly, we only touched on this latest threat to Medicare direct contracting entities, and that we'll get into in some detail in a few minutes. These DCEs, direct contracting entities, it is a complex subject. And I'm going to approach it the same way I approached the explanation of the healthcare reform debate, by walking you through the history of it. And it's about 30 years old now. Congress has been obsessed with overuse in the traditional Medicare program for a long time. And their obsession with overuse within the traditional Medicare program is what gave birth to direct contracting entities. And it helps to understand the history of that obsession and how it has affected traditional Medicare. The last comment I'm just going to make is that the 3 webinars together took about 3 hours of people's time to watch. Not everyone is going to give us 3 hours to help to explain the healthcare crisis. But that's okay. We need all kinds of people in our Army. We need people who understand health policy inside and out, as well as people who only have enough time to maybe write several emails per year. But I want to stress that it is essential that some of us understand why US and Minnesota costs are so high, and conversely, what's not causing the problem. It's not overuse. And specifically, why managed care has failed for 50 years and why it will always fail. There are numerous situations where the knowledge on those topics is going to be very useful. Let me just close with a quick example, a fun success story in the single payer movement. In the fall of 1996, in September 1996, I got a call from Lori Sether at the Star Tribune. She said they wanted to organize a debate between a single payer advocate, a managed care advocate, and a high deductible advocate in front of a citizens jury, a group of 14 people that they would select to represent all Minnesotans, rural, urban, Republican, Democrat, Independent, men and women. And they wanted to know if I would participate. Of course, I was glad to participate. It's rare that the single payer movement is offered an opportunity to engage in a fair fight. She said they were only going to allow us 5 minutes to make opening statements, and then we're going to let the jury ask questions for another 2 hours. I was very fearful that it would turn into a Tower of Babel. This is a complex topic. Things need to be laid out in a certain order. I said, well, how about 10-minute opening statements? And we can bring handouts. And she said, good. Well, in the end, I was the only one that brought handouts, but I could tell people were looking at them. I didn't use any of my 10-minute opening statement to talk about how bad the system is. I knew they knew how bad it was. I used my 10 minutes to tell them why managed care has failed and why the high deductible advocate was also wrong for endorsing the overuse diagnosis. My opponent was Michael Scandrett, at that time the CEO of the Minnesota Council of Health Plans. And the gal representing the high deductible camp had just left the Department of Health to promote high deductibles. After 2 hours of back and forth with the jury, the League of Women Voters official who was emceeing the event called to quit, asked for a vote, and the first several votes down the line were for single payer. I thought, oh, wow. I was surprised people were even prepared to take a vote. The ultimate outcome out of 14 people was 8 for single payer, 2 for managed care. One lady wanted to split her vote between single payer and managed care. I don't know how you do that. So it was 8.5 for single payer, 2.5 for managed care. Nobody voted for high deductible policies, and 3 people abstained. So the lesson I drew from that is, A, single payer wins in a fair fight, and not by just a little bit, but by a landslide, even in a somewhat chaotic debate like that one. And secondly, people really do enjoy hearing why the healthcare system is so screwed up. They appreciate someone leading them through the history of the debate and telling it to them in a way that when it's done, they go, oh, I get now why we're in such a mess. And I understand what Michael Scandrett is saying. I understand what Kip is saying. I understand what the high deductible lady is saying. So I appreciate having had the chance to present all this to all of you. And I hope that we can make use of these webinars down the road.
So we have 15 minutes for this section. If people would like to, I invite you to turn your videos on, because it's meant to be a meeting this evening instead of just presenters talking at you. If you would be willing to turn your videos on, but leave your sound off unless you would like to ask a question. Anyone who would like to ask a question of Kip, please, if you know how to do the raised hand, which is, I believe, in the reactions section of your toolbar in the bottom, raise your hand. If you can't figure that out, wave your hand and we'll try to watch the screen. This is your chance to pick Kip's brain about
I see Steve.
failures about our current system.
Tim Burkhart, haven't seen you in 100 years. Hi.
So maybe as a general comment, what Kip has talked about for the last 3 sessions is literally 45 years of attempts to contain costs based on rather flawed analysis of the problem. And we keep doing it over and over. How can we get out of this, off this treadmill and onto a path towards some real solutions? That's always nagging at me. Anybody else?
And that question also applies to this crazy direct contracting entities.
Mm-hmm.
It is really a flaming example of Congress and its advisors persisting
Mm-hmm.
on a diagnosis and a solution that has been proven now not to work, and they just won't pull the plug or even admit that the previous iterations didn't work. It's like a zombie religion. It just goes on, and there's no, it's going to take political power and a lot of education to stop it. I mean, we need to stop the Medicare privatization, and we need to stop direct contracting. And if we do, that will be a terrific victory. But we can't stop there. We're going to have to go beyond that and root out this fervent belief that overuse is the problem within traditional Medicare and the entire system. And someone's got to do the dirty work.
I see Sharon and Steve. I don't know who put their hand up first, but
Steve
Sharon,
did.
who?
Steve
Sharon.
had his hand up first.
Oh, Steve. Okay. You want to? Thank you.
Yeah, Kip. I'm really interested. Why is it that the media cannot understand or cannot get on board with this managed care problem?
I think it's because, I don't want to be too cynical, but they chase objects and issues that have lots of events going on. And unless there's a hearing in the Minnesota legislature, or a bill is moving, or a candidate is really making healthcare reform a major issue, then they feel like there's nothing to talk about. And just to haul off and start covering the debate about whether overuse is a real issue is just a non-starter. I do wish their editorial boards would recognize that even though this may not be something in the news, this is really something that ought to warrant an occasional op-ed from troublemakers like us.
Okay, next is Sharon.
I was, and maybe other people having problems, but my computer told me I had to update and I couldn't get my picture to come up. So it took me a while. So I'm not real sure if this is an appropriate time to ask this question, but a congressional representative of ours I read in the Minnesota Post that she's supporting Reassurance, which to me, is, I don't know if that refers to Medicare or Medicaid or every insurance. I don't know, Kip, if you know, but it just seems to me that's the wrong way to go. They don't need more money for reinsurance.
Well, if they were talking about reinsurance, that's an awfully esoteric topic. It's actually being discussed within the Medicare Payment Advisory Commission as a way to make life a little easier on the poor, underprivileged Medicare Advantage plans. The government would basically buy insurance, and the insurance, I presume it would be privately financed, would pay for really expensive cases so that the poor, underprivileged Medicare Advantage plans don't have to pay for the most expensive patients, say those who cost more than $200,000 per year. And I'm surprised anybody's talking about that. I'm following the Medicare Payment Advisory Commission, and I know that at their last several meetings, they're talking about that.
Okay, I just read it in the Minnesota the Min Post last week, and that's about all they said, was that our representative is supporting reinsurance. So I didn't know the context.
Well, send me the address. I'd like to, I mean, you got my email. Send me the link if you can.
Okay.
I can comment, or else Rose can comment. In the state legislature, at least in at least the last two bienniums, commercial insurance companies have come to the legislature asking for lump sums of money to cover their high cost, as Kip said, higher cost patients. And the leverage they use is they kind of threaten that premiums will go up if you don't give us this money. So they kind of hold the legislature hostage to giving them additional money to sort of quote unquote keep premiums low, which we all know is, but we have no, so when that gets voted in, there are no strings attached. There's no real way of knowing if they actually reduced or controlled the cost of premiums. It's a, what do you call that? Hostage taking kind of situation.
Yeah. Well, our DFL wants to write to our congressional rep. So I think it's important we find out in what program is she supporting that, because I don't think any program she should be supporting it, because we're trying to go single payer where the government would take the risk, not the insurance company.
Democrats generally oppose, but they get a little bit threatened, as does the governor, about the threat of rising premiums tends to create some pressure. Okay, Judy, go ahead and recognize.
Sure. Our next question is from Matthews. Thank you, Sharon.
I have a question about marketing. Obviously, we just came off the open enrollment period. And I would say that I saw 2 ads total from Medicare itself. And I saw hundreds of ads from Medicare Advantage. And I wonder whether there's some talk anywhere, maybe in administrative level or in legislators, among politicians, or among us, or among anybody, about the asymmetry in marketing. You have vulnerable people. I mean, I worry all the time about health costs, of my own health costs, so that makes me susceptible to very deceptive ads if I didn't know better. And I can just imagine there must be tens of thousands of people out there watching all these ads during open enrollment, and all they ever see is Medicare Advantage almost. And so that asymmetry is just keeping the voting public confused and propagandized, in my opinion. So I wonder about that. Is there anything we can do to change them, to to introduce some equality into the marketing during open enrollment or any other time.
Matthew, that's a wonderful idea. I had the same thought. Again, sort of closing my eyes at the 50,000 Medicare Advantage ad. Nobody is representing traditional Medicare with the same hoopla and enthusiasm that the overpaid Medicare Advantage plans are representing their industry. I think it's a legitimate request to make. I don't think we're going to be able to just terminate the overpayments to Medicare Advantage overnight. So we have to start thinking about incremental approaches like that that begin to cut into their ability to enroll millions of more people every single year. The encouraging signs are PNHP's campaign, and there's a growing outcry against these direct contracting entities. Donald Berwick and a guy named Gil Fillan, who used to run the Center for Medicare and Medicaid Innovation, posted a 2-part article on the Health Affairs blog, pieces of which I disagreed with, but they blasted the overpayments to Medicare Advantage. And Berwick, as you may know, used to be the administrator of CMS under the Obama administration. So we're beginning to, and I've heard that Congress is starting to worry about the vast overpayments, both due to the lousy risk adjustment and to the aggressive upcoding that what we talked about in the third webinar. So there are signs in the wind that the resistance is rising. Whether it will be enough to make a difference anytime soon, I don't know. But I like your idea. I think it should be on the table.
Thank you.
Thank you very much. Next question is from Tim.
There, now I'm unmuted. Good to see all your smiling faces again. It's been a while since I've been able to partake in some of these Zoom conversations or any in person, but I saw the latest notice and I really wanted to weigh in and bring myself more current with the group's thinking and the feeling in general about where we're headed and what's possible going forward from here. We've been working on this for only, 3 decades now, or thereabouts, Kip longer than anyone else. You know, if you see William Shatner and Joe Namath and Jimmy Walker doing all these Medicare Advantage ads and more, it certainly plays to the vast majority of the people sitting on this Zoom tonight. They're catering to the boomer generation because we're at that age where it's open enrollment time for the heavily subsidized Medicare Advantage plan, and that's all they're pushing. You know, there has been move in the past to try to restrict prescription drug advertising, and you can see that really hasn't been very successful because there seems like there's even more of that than there ever was before with brand new drugs that somebody sits in a room somewhere and makes up names for these things, but they're going to cure everything. And the list of side effects, of course, is 10 times longer than the drug itself. So I had the privilege, I guess I say that tongue in cheek, the last couple of days, our Minnesota Association of Small Cities, of which I'm a member, we've had Zoom meetings with all of our congressional delegation, from Angie Craig to Tom Emmer to Jim Hagedorn to everybody in the congressional delegation has been contacted. We've had conversations with them. Unfortunately, we don't really get to push too much on healthcare issues. It's all roads and bridges and infrastructure. And the funny part was, if there is a funny part to it, the people who are sitting on the right side of the aisle, the right wing side of the aisle, they're the ones that talked in terms of politics. The people on the left side talked in terms of policy. And I think that's always been the case. And maybe that's why many times the arguments are lost. We're doing battle with people who are talking something else that incites their base, gets people excited, mad, and angry, and motivates them. And they really have poisoned the well to a lot of these conversations. You know that there's a lot of people that are believing a lot of strange things nowadays, and they're capitalizing on the fact that these people, for the most part, if they follow their media source, they believe everything as gospel that comes down the pike. And that includes prescription drug pricing is government overreach. You can't be imposing those price controls, even though we're the only country in the world of our size and our composition that doesn't do that. It doesn't take care of the welfare of our people. So it's a frustrating yet still worthwhile cause for us to push together. And I think the next set of elections are the opportune time again for us to make our voices heard, try to reach those people that could be convinced and perhaps get a few more on board, to really think in terms of protecting people as opposed to protecting the companies, the drug companies and the insurance companies who are basically draining the economies of our country. And I think it's time for us to re-examine our commitment to this and jump in and do what we can. So that was more than 2 cents worth. I'm sorry to take up that much time.
So Tim, you have provided a wonderful segue into a few thoughts I wanted to share this evening, just before we turn this over to turn it over to Kip for part 2. I wanted to comment on some thoughts about public solutions to very big public problems, and I'm going to ask that we take a step back and think about what's behind the opposition to public solutions for our biggest public problems. We are seeking a legislative solution to the problems we see with cost, quality, and access to healthcare. So we have to understand some context. This threatens the business model of the for-profit side of the medical industrial complex and the influence of the big nonprofit health systems. But underlying the corporate and organizational dynamics is a decades-long push to assert the primacy of private property rights and resistance to the use of public resources to assure equal protection. My belief is that the current assault on voting rights is the latest in a decades-long campaign to undermine liberal democracy and the common good in favor of a corporate takeover of the courts, the Congress, the presidency, state legislatures, local governmental units, the media, all forms of the media, academic institutions and schools, our legal system, religious organizations, even by a variety of well-organized and well-funded strategies. I'm not trying to make everybody discouraged and depressed, but I just think we have to be really clear-eyed about the task in front of us and the threats to our goals. One of their primary goals is to privatize public programs and institutions, weaken consumer and environmental protections, and undermine efforts to leverage public solutions to solve critically important public problems, including healthcare. So think, this includes privatizing public schools, national parks, public lands, natural resources, the U.S. Postal Service, the Veterans Administration health system, parts of the military, public infrastructure, housing, and healthcare, including Medicare and even Social Security. Think back to the George W. Bush administration. He was proposing partially privatizing Social Security and handing our money over to the casino on Wall Street. It was only stopped when he crashed the entire economy in 2007 and 2008 and had to give that up. As I said, I don't say this to discourage us. I just say this to alert us to the need to combat this well-entrenched anti-government ideology so that we can effectively counter an illiberal and dangerously anti-democratic set of forces. Strengthening democracy will help us put and keep in place the legal and governmental systems that we need to protect our freedoms and our ability to influence our government. And I included a few slides to reinforce this, but you'll just have to get them in the post-meeting slide set because I want to go back to Kip. I did include a list of public services that we all depend on and that we do together. And I think one of the things we need to do is change the narrative going forward and say that there are things we do together that it's more efficient, more equitable, and actually more cost effective to do together. So, and I've included my short reading list on this subject in case you're interested. So that's next up, we have Ken Engelhardt and Rose Roach, who will be talking about, Ken's going to talk about building a coalition for reform, because we've got to stop this and we've got to build something better. And then Rose is going to talk about the new Minnesota Health Plan Caucus here in our state. So thanks a lot, Ken. Ken, you need to unmute.
There we go. Can everybody see this?
Yes.
I'm going to go ahead and
Yes.
try
Yeah.
going from the beginning. Okay, so what I'm going to talk about is the health justice campaign that we're doing as part of Healthcare for All Minnesota and a number of allied organizations. This slide shows the team that we have that's called the Coalition Builders Team that's working on building a health justice alliance to pass a single payer bill such as the Medicare or such as the Minnesota Health Plan and improved Medicare for all. So this entire health justice campaign really wouldn't be possible without the people that you see listed on this screen. All these people have recommended an organization, and even more than one organization, with whom we can affiliate, and they actually serve as liaisons to those organizations. I have to particularly point out Rose. Rose Roach is the co-leader for this and has helped us greatly with aligning with unions, and also has served to connect us with the legislature. But I can't thank these people enough who are listed here on the sheet for all the work that they've done and making this whole thing possible. What we are doing is, it's called an inside-outside campaign, and I'll explain that in just a little bit. But our purpose is to campaign for a single-payer health program, whether it be the Minnesota Health Plan here in Minnesota or improved and expanded Medicare for all, HR 1976 nationally. The inside part of the campaign is working with Minnesota state senators and representatives who are forming a Minnesota Health Plan Caucus. And the outside part of the campaign is us. It's the grassroots Minnesota organizations working on this as citizens in collaboration with our legislators. Here is a listing of what we would call the outside part of the campaign, the grassroots part of it. This is a listing of health justice allies, organizations who have sent at least one representative to what we call Health Justice Allies meetings. We've had 4 such meetings, and you can see that they represent a variety of categories, whether it be business or rural Minnesota, or progressive advocacy groups, labor groups, Latinx, LGBTQ, or physician groups. So these are the allies that have attended at least one of the 4 Health Justice Allies meetings. There are other organizations that have said we're on board with you guys, but we've just got so many irons in the fire, we can't take the time to make the key allies meetings, but we're with you. So in total, we have about 24 organizations if you count all of those that have made some form of a commitment. We've also been getting guidance from Healthcare Now. The leader of that is Benjamin Day, based in Boston. And Healthcare Now is a national umbrella organization for the single payer movement. And we've really appreciated the advice and counsel that they have given us. So that's the outside part of the inside-outside campaign. Next is the inside part of the campaign that has to do with those within the Capitol, forming the Minnesota Health Plan Legislative Caucus. The authors of the Minnesota Health Plan are Senator John Marty in the Minnesota Senate and Representative Cedric Frazier in the Minnesota House. The caucus leaders for the Minnesota Health Plan are Senators Jen McEwen and Omar Fatah. And in the House, the leaders are Representatives Liz Bolden, who happens to be a nurse, and Liz Ryer, who was a researcher, I believe she said for at least a decade, with Blue Cross. And also a leader in that caucus is Representative Cedric Frazier. And what the caucus is planning, they're in the process now of having monthly meetings. Their first meeting had a tremendous turnout with dozens of enthusiastic legislators attending. They plan an official caucus launch sometime in early 2022, around the time of the legislative session. They're planning on hopefully having informational hearings. We've requested those hearings in the Minnesota House, and they're planning on having statewide town halls. And so what type of progress have we made so far in the 4 meetings we've had with the Health Justice Allies? Well, for one thing, we've gotten to know each other better. There's several organizations, several people involved, and it's always good to know who you're working with and to develop relationships with them. The allies have been asked and shared their experiences with the U.S. healthcare system and how that affects their organizations and members. So they've been given voice to express their involvement and their experience with our so-called system. We have shared some basic healthcare facts with the allies in these meetings about our deeply flawed model. One that I shared at the last meeting last week was the problem of 1/3 that we currently have going on, where 1/3 of the payments that we pay as patients, whether they be premiums, deductibles, co-pays, co-insurance, reinsurance going out of our tax dollars into commercial insurance companies. 1/3 of our dollar that we spend on healthcare is wasted in some form or another, whether it be CEO salaries, all those advertisements you see on TV for Medicare Advantage, they are wasted before any patient care even begins to get paid for. So they're wasted on the corporate bureaucracy and corporate greed. The other 1/3 is that 1/3 of GoFundMe campaigns, 250,000 of the campaigns a year, go for people going online, pleading for help to pay for their medical expenses that they can't pay, that their insurance won't pay, and they're just struggling to find a way to pay their medical bills. And the last 1/3 I want to talk about is that 1/3 of patients in our country skip some form of treatment because of the cost involved. That treatment can be a follow-up visit with their doctor, physical therapy appointment, medication, that type of thing. And what do these 1/3 lead up to? They lead up to tens of thousands of people in this country who die unnecessary deaths because they can't get the health care they need. And can you think of anything more tragic than somebody dying and they don't have to die? It can be prevented. I mean, that's about the most tragic thing I can think of. Also at the last Health Justice Allies meeting, Ann Jones gave a presentation on the many benefits, the many positives of improved Medicare for All and the Minnesota Health Plan. And Ann talked about what we hear so often, the public option. And she talked about ways to pay for the Minnesota Health Plan and improved Medicare for All. Out of these 4 meetings that we've had with the Health Justice Allies, the allies are pretty much unanimous in agreement that we are in a healthcare crisis. They get it. They get we have a huge problem here and it's unsustainable. And what we're working on now is pulling together a working group to come up with an organizational structure for all of these organizations that are part of the Health Justice Allies. And the timing of that working group we're working on right now because of the plans that the Minnesota Health Plan Caucus has for early 2022. So we're trying to coordinate our work with what's going on in the Minnesota Health Plan Legislative Caucus. So I'd like to just say a few things about what I would say are possibilities and action. I really think we can get this done. I think we can get there. I think it's going to be a long, hard battle, but I think we can get there. It won't happen overnight, but I wouldn't be doing this type of volunteer health advocacy work in my retirement years if I didn't think we could get there. I really strongly believe we can get there. It's going to take a massive movement of the people to get this done. But just think of the possibilities. We could have all of our medically necessary care paid for, including dental, vision, and hearing, including long-term care if it comes to that, including reasonable prices that we pay for prescription drugs. We could have the freedom to choose any doctor, clinic, or hospital in the country we wanted, rather than being told by the insurance corporations that you have to find doctors, clinics, and hospitals within the network, and then being liable to getting hit with a surprise bill. And we can have the freedom of dealing with our medical illness without the stress and worry of worrying at the same time, how are we going to pay our medical bills like patients did when they were about to be intubated in the ICU because of COVID. They would ask, who's going to pay for this? We shouldn't have to deal with that additional stress and worry when we're dealing with serious illness. So the part of action I want to talk about, I think most of us on this in this meeting are activists, but that's how it's going to happen. We have to act, and we have to get others to act. And sometimes it can be just so easy, really, to take action. Making a phone call to the senator, to your representatives, that can be done in about 3 minutes. And if you choose to write an email, that might take 4 or 5 minutes. It's so easy to get the action step done sometimes, but we have to take action, or this just isn't going to happen. It's going to depend upon us acting. We have to be promoters of the single payer program, and almost missionaries in a way to convince others, our neighbors and our friends, to do the same. Just as an example of that, I'll give you an example of my wife Carol. This past week, I was walking our dog in the alley in our neighborhood, and there's a neighbor there that has an interesting van, and he's a jazz musician with his equipment in that van. And she started talking to him, and there on the spot in the alley on his cell phone, he signed up for Healthcare for All Minnesota. He's a new convert, and we got to find a lot of new converts to take this type of action. So I really encourage you to keep on keeping on. If you haven't been engaged, please do so. Please take action. It's going to take all of us and a massive movement of people to get this done, but I really think we can get it done. And having said that, I want to bring Rose on and tell you some good news about a meeting she had with the Minnesota Health Plan Caucus. I believe it was on Monday of this week. So I'll turn it over to you, Rose.
Thanks, Ken. Hey, everybody. So just to give a little bit of a context, I think most everybody knows that on a national level, we have a Medicare for All caucus in the, I believe it's just on the House side at this point, although I think Bernie, of course, is a member of it. But the idea being that those who support Medicare for All as seated legislators get together and they help promote it, and they educate around it, and they hold district meetings, and they really push for this as the obvious fix to our broken healthcare system. So the legislators here in Minnesota decided, why not have one of those here? And so we have a local Minnesota Health Plan Caucus. And I cannot stress enough what a significant development this is for our movement. Ken talked a little bit about the inside-outside strategy, but building political power inside as we build both political and grassroots power on the outside is critically important to being able to really move this legislation and get it passed. So I was honored to ask and come do a presentation to the caucus members last Monday. I decided I'm not going to talk to them about single payer. I mean, for heaven's sakes, they're already co-authors of the bill, right? They get it. So what I wanted to do was what Kip has been doing for us over these last 3-4 months, and help them understand and raise red flags for them when they start hearing, whether it's from the industry or whether it is from agencies within government that handle our healthcare programs, or even possibly fellow legislators, whether they're Democrat or Republican, because this privatization of our healthcare in this country is bipartisan. It has not been happening strictly under a Republican administration. It is absolutely bipartisan. And so I wanted them to be like thinking when they hear about ACOs or IHPs, integrated health partnerships or whatever, they immediately go, wait a minute. I've heard of those before. Before you start talking to me about anyone, I want you to prove to me that they've been working, and how have they been not controlling costs, but controlling price, because price drives the costs, right? And to really, really give them a little bit of a deeper dive in the historical perspective that Kip has done such amazing work in resourcing and laying out for us, so that they would be able to really be grounded in why they support the Minnesota Health Plan, and be able to fight back on this constant drumbeat that we can somehow fix the system if we just do these market-driven, market-based solutions, because we can't. We all know that cost containment is key to achieving universal health care, but trying to do that within this current system is never going to happen because it just costs too much. So I asked the legislators, I said, seriously, isn't it more politically feasible to get the cost of care down than to add complexity and fragmentation, which only adds and increases costs? And I also challenged them on political feasibility in general, and said, seems to me you all have a big part in political feasibility. So if you don't get to say that it isn't politically feasible, we'll help make it politically feasible, but you got to be on that bandwagon along with us. I made the case that the crisis is now. We can't keep tinkering. We know what needs to be done, and it's time to have the political courage and to be bold and to do it. The voters are overwhelmingly with us. I said it isn't about being politically correct. It isn't about, but it's about having knowledge of how we got here, whether through a Democratic or Republican administration. So it solidifies, our position on the only way to guarantee truly healthcare for all with no exceptions, and that is through the Minnesota Health Plan or Medicare for all. The presentation was really well received. Lots of really good questions. They were engaged. They asked me to come back, which is encouraging, to keep talking about this stuff, why it doesn't work and how it doesn't work, and how they can in turn challenge it as seated legislators, and instead turn that conversation over to where it needs to go, which is let's do the Minnesota Health Plan. So thanks for letting me report out. It's really very exciting what's going on there.
Thank you. Thank you so much, Rose. I couldn't find my unmute button. Can everyone see the last couple of slides? And I'll just talk about Ken alluded to the person missing from that list that he showed you on the slide is you and all of us. And it's all about grassroots support for change. So I'm sending you just a few of the, you've seen this before if you've attended any of our events, things we can do now, not until it's safe to do so. So a lot of our work is still going to have to be virtual, but we still can all talk to our family and friends about this issue. It probably comes up in conversation, but share what you know, and help us start adding to that army of people it's going to take, because we have to give those political leaders kind of not only the push, but the wind at their back to make this change and the support they need. A little tool for you to keep track of conversations that you've had. We'll send this out in the slides and as a as an attachment. The more you know, so we've got resources for you. And then I'm going to just make a couple of announcements. Just this is our last event for this year, our educational event for you this year. So thank you again for attending, and thanks for all that you've done this past year and what we will do going forward. The next thing on our calendar is January 13th, and it's going to be led by Physicians for a National Health Program Minnesota. It's their annual meeting and a program, and we will have a staffer from Representative Jayapal's office, a panel talking about what the reality of the so-called public option proposals. It's more than one, and then their 2022 goals and some fundraising. So that's just a little preview of what we've got coming up next year. Then a call to action on the threats to traditional Medicare or traditional or original Medicare. You may probably got a call to action from us already, asking you to call your member of Congress, senators and representatives to ask them to halt this direct contracting entities portion of this new payment model that's being proposed that is very, very, it's a very serious threat to traditional Medicare. They're looking to scoop up the 30 million people who have chosen traditional Medicare and add them to the rolls of people who are feeding the for-profit. And now the new threat is that people could potentially be assigned, people who have chosen traditional Medicare could be assigned to some sort of either insurance investor-owned for-profit entity that would, against their knowledge and or without their full understanding and against their consent, that would really has the potential for ending Medicare as we know it. And as Kip said, we need Medicare intact to build on for a improved and expanded Medicare for all as a national health plan. So two asks, and since we sent out that call to action, we've gotten also a call to action from PNHP, Physicians for a National Health Program, the national organization, letting us know that Representative Pramila Jayapal has written a letter to every member of Congress, asking them to have HHS halt this direct contracting entities demonstration or proposal. So it's kind of two things. And I've got language that you'll get in the slides. So those two asks your members of Congress to ask HHS or direct HHS to halt this program, but also sign on to the letter Pramila Jayapal has written. And then the next ask is call HHS Secretary Javier Becerra directly and ask him to end the Medicare direct contracting program immediately. This is some of the language you can use if you get a staffer on the phone or if you are able to leave a message. If you leave a message, whenever you make a call like this to a member of Congress, leave your name and address and state that you are a constituent, ask for their support on this issue, give your phone number if you would like a call back. Phone numbers for you are on this slide. Also, there's a direct number for HHS Secretary Becerra, but the comment line, when I tried to call, I had to actually get shifted to a comment line, and that's the number down below. That's 205-5445. So hopefully that's kind of understandable. Also, I put in the chat the PNHP website. They are a dues-based organization and well worth the dues, by the way, for the newsletters that they send out and the power that we can give them by having more members. You don't have to be a physician to join. You can be a non-physician or other healthcare provider, but it doesn't cost anything to sign up for their alerts. So if you wanted to put your contact information, you could get alerts directly. And then, so they gave directions, for example, the language to call in for this latest one that we got, I think yesterday or today. So contact information for our speakers here on the screen. Thank you to our presenters for this evening. Thank you all for hanging in there with us, and wishing you happy holidays. We all need a little breather and break from issues. Best wishes for happy and healthy holiday season for you, your family, your friends, and we will see you in the new year. Judy, would you like to finish up for us?
I sure can. I just, again, thank you everyone for coming and participating. If you guys have questions, you can always email me at info@hca-mn.org, and I can always get your question to the correct person to get answered. We will be sending out the recording and the PowerPoint presentations and other things probably early next week if I don't get to it tomorrow. So be on the lookout for that. And thank you again all for coming. I appreciate it. We all appreciate it. Have a good evening.
Should we do the Zoom wave?